Assalamu alaikum. Welcome to you today clinical case presentation. I am Dr. Fuadin Bashar, RMO, Medicine Unit, Barden General Hospital, Bangladesh. My case: a young girl with patient Miss X, 14 years old female, heading from Bangshal, Dhaka, admitted in our hospital on 28 August 2000 with a complaint of fever for 3 days, cough and chest pain for same duration. According to the statement of the patient, she was reasonably well 3 days back, then she developed high-grade fever without chills and rigors, with the highest recorded temperature of 103 degree Fahrenheit and lowest of 100 degree Fahrenheit. Patient took antipyretic for her fever, but fever did not remit completely. There was cough which was initially dry, but eventually became productive with whitish mucoid sputum and did not contain any blood. She also had right-sided chest pain which aggravated with coughing and deep inspiration. On query, she gave history of loss of appetite with weight loss of around 3 kg in last 3 months. Her bowel and bladder habit was. She did not complain any burning sensation of micturition, abdominal pain, joint pain or skin rash, or loss of consciousness or seizure. There was no history of recent travel, blood transfusion or exposure to pets. But actually her history did not end here. 1.5 years back, she had a history of 6-month fever in relapsing and remitting course, for which she was hospitalized for several times under Department of Pediatrics. However, her fever had no focal feature and she was eventually referred to the Department of Internal Medicine for further work. She was discussed in our medicine grand round. She underwent thorough examination repeatedly and relevant investigation including imaging, screening for infection, ANA, ANCA, ENA profile, bone marrow examination and lymph node biopsy were done. But reports were inconclusive except feature of anemia, chronic disease, high ESS, CRP and weakly positive ANA that subsequently became negative. So with those inconclusive findings, her case was discussed repeatedly among us and ultimately she was prescribed oral prednisolone, keeping in mind the possibility of an underlying autoimmune disease. Interestingly, her fever subsided within a week and the steroid was gradually tapered off in around 3 months with meticulous follow-up. After that, she was reasonably well for about 9 months. With this background, she was admitted under medicine department for further workup. History of past illness. She had a history of skin tuberculosis and received anti-TB medication 8 years back. And socioeconomic, personal, family history are nothing contributory. She belongs to low socioeconomic background and her menstrual cycle was regular with average flow. She was immunized as per EPA schedule. On her treatment history, she got tablet paracetamol capsule cefixime 200 mg before admission. On general examination, she looked ill, below BMI, mildly anemic, temperature 102 degree Fahrenheit. On vitals, pulse 110 per minute, regular. Palpable but feeble in left radial artery. Right radial pulse not palpable. Blood pressure on left arm 85/60 mm mercury. Right arm not recordable. Other findings was unremarkable. Examination of cardiovascular system reveals regular low volume pulse, right radial brachial pulse not palpable. All other peripherals are feeble, no radiofemoral delay. There was left carotid and both subclavian brui. Blood pressure already mentioned. Ankle brachial pressure index 1. No postural drop, JBP not raised. Precordial examination was in case of respiratory system examination reveals no abnormality except crepitation present over right 7 to 8 intercostal space along the dorsal scapula. In case of alimentary system examination, her bowel habit was normal, abdominal aortic brui and bilateral renal brui present. Nervous system examination was within. So, slide picture. A 14 years old normotensive female presented with high-grade fever, cough with whitish mucoid sputum, and right-sided fluidic type of chest pain for 3 days. There was also anorexia with significant weight loss for last 3 months. She had a background history of pyrexia of unknown origin for 6 months and received oral steroid that was subsequently tapered off in 3 months along with improvement of her symptoms. On examination, she was mildly anemic, tachycardic, febrile, regular and low volume pulse, but right radial and brachial pulse were not pulseful. All other peripheral pulse were feeble. There were also left carotid, both subclavian, abdominal aortic, and bilateral renal V. Blood pressure was 85/60 mm mercury. There was no lymphadenopathy or organomegaly of any other focal sign except crepitation present over right 7 to 8 intercostal space along the dorsal scapular line. So, what the provisional diagnosis? My provisional diagnosis: right-sided pneumonia with Takayasu arteritis, and I have a differential like tuberculosis. So, what are the investigation we prescribe for the patient? Advice: in case of complete blood count, her hemoglobin was 10.2 gram per dl. Total count of race 18,730 neutrophilic leukocytosis. Platelet 5 lakh per centimeter cube. ESR 190 mm in first hour. CRP 166 mg per liter. Here we show in chest X-ray peer view. We show a cavity-like lesion in right lungs. This is right lateral view. On a sputum examination, gram stain showing gram positive concave and gram negative bacilli plenty in amount. A bin first and second sample was negative, gene expert negative. Also showing growth of candida species. Monto's text. In case of imaging, ultrasonogram of whole abdomen showing no sign, but CT aortogram findings was remarkable, like moderate diffusely narrowing in left common carotid artery. There was also narrowing of proximal right common carotid and subclavian artery. Gradual narrowing of abdominal aorta after origin of celiac artery. Both renal arteries are narrow, more in origin of left. Here we showing gradual narrowing of the abdominal aorta, then narrowing present in both renal artery. Narrowing also present right brachiocephalic trunk, left common carotid, and left subclavian artery. Yeah, there is typical findings in Takayasu, where gradual narrowing present in abdominal aorta and both renal artery, more in left renal artery. Duplex study of both lower limb showing mild flow reduction about 50% in all the arteries of both lower limb. Urinary blood urine CS was in within normal with our ECG normal. ECO showing abdominal aortic tracing has diastolic splice. This is indicating some obstruction at distal aortic level. Liver, renal, and serum electrolyte other vitamin calcium was normal with excess serum albumin 29.7 gram per dl and vitamin D deficiency. So my final diagnosis: Takayasu arteritis type 5 and right-sided resolving pneumonia. We treated the patient with antibiotic, prednisolone, azathioprine, calcium, and vitamin D. After subsequent follow-up, patient right radial pulse now present but feeble. Right arm blood pressure 75/60 mm mercury, left arm 95/70 mm mercury. Right carotid, abdominal, right renal, left renal, V present till now but milder in intensity. Both subclavian V absent. Hemoglobin raised to 12 gram per dl. CRP decrease and temperature 98 degrees. as we treat the patient with steroid and immunosuppressors. So we regularly follow up the patient blood glucose profile, like her first 2 weeks are within normal limit. Her vitamin D now 44 nanogram per ml, BMD minus 1.2, serum basal cortisol are 391.97. Her follow-up extra was normal. For patient satisfaction, pattern done PET scan report in India, which showing to see any evidence of active disease, which showing findings of concern for Takayasu arteritis type 5 and no evidence of active disease. So now move on discussion. Takayasu arteritis is chronic idiopathic inflammatory disease that primarily affect large blood vessel like aorta and its primary branches. Patient may present initially with constitutional symptom but later develop symptom associated with vascular. It's more in female, male to female ratio 1:9. Here we show the course of the disease. At first, patient present to us with a complaint of fever, weight loss, joint pains, lymphadenopathy, and others constitutional symptom. But now patient present us with vascular insufficiency like stenosis, and we hope patient may go into remission. So to determine the TAC activity, we should follow this guideline, like if patient's constitutional symptoms are absent, inflammatory markers become normal and no new imaging findings, that we call the patient is now on remission. And if remission criteria is at least 6 months, then it's called sustained. According to radiological classification, our patient was in type 5 Takayasu arteritis, which means generalized involvement of all aortic. In case of prognosis, approximately 20% patients have self-limiting disease. In remaining 80% patients who are immunosuppressive therapy resulted in remission in 60%, and one have experienced relapse after immunosuppressive therapy was stopped. So thank you for patience hearing, and this is our National Language Day. So সকল ভাষা শহীদদের প্রতি বিনম্র শ্রদ্ধা, ধন্যবাদ।